Welcome to The Local Lens. I'm Jenny Pastusak, and I'm really excited about today's guest. Kat Rodgers is the Director of Community Health Initiatives at Tidal Health. Kat, thanks for joining me.
Thanks.
So, community health, that's pretty broad. Maybe you can start off by explaining what it is and how you kind of got into this role at Tidal Health.
Yeah, sure. It's very generalized, as you can imagine. A lot of people like to specialize in things, but what I love about community health is you get to see the big picture, and you get to work both like within the healthcare setting, but with partners who you wouldn't even normally think of when you think of healthcare, because everything is community health, right? It's where you live, it's the water you drink, it's education, it's the food you eat, it's the physical activity you get. So I have always sort of been a big picture person. And as we were talking earlier, my career started way back when in journalism, because I didn't really know what I wanted to do. I wanted to learn about everything. And over time, I was very good at communications, but I sort of gravitated toward the public sort of sector, and I ended up in emergency management and doing crisis communications, and from there I started to discover public health and the role it was. So I ended up working at a local health department, and then eventually made my way over into the hospital setting because they were doing population health, and that was new for a hospital. So
I remember when it was called population health. And now is it the same, like population health, community health, same kind of bucket?
Yeah, people use it interchangeably. So there's sort of three things. There's public health, population health management, and community health. So public health is really the government and the standards and the competencies that we need to have. You think of disease surveillance, environmental health, food inspections, those kinds of things that you need to have. The infrastructure is more public health and very focused on prevention. And then population health in a hospital is managing the health of the patient population. So what are the conditions that are affecting your patient populations and different populations that are interacting within the healthcare system? May or may not be, those populations can overlap, right? So public health is for everybody, and then population health is interacting with the healthcare system, and community health is kind of right here in the middle. I have a little bit more flexibility because I'm not, part of the public health department, but I'm an offshoot of population health management. So my team is outside of the hospital, and our major focus is doing what we can to keep people out of the hospital.
Okay.
So we are in the community.
And that's what is so important, to keep them from being, admitted to a hospital where no one really wants to go, or when they're released, they don't want to go back. And I think readmissions are a piece of the hospital piece. Let's not have you come back.
Yeah, and you would think hospitals, want volume, they want people coming, but they want people coming for, maybe elective surgeries, right? Or they want people going to primary care. Ever since the Affordable Care Act in 2010, healthcare systems have been pushed to focus on value and quality and equity and prevention and managing chronic diseases, and have started to get dinged if people keep coming back to the hospital for things that could be managed in a primary care setting.
Yes, or at home even.
Yes, or
at home.
At home, where it starts, I've been thinking lately, we need to be doing more with our youth and really going back even farther with prevention. But for the most part, our department has been focused on chronic conditions in adult populations.
Okay, so what does that look like? What are some of the programs that you have in place that you implement to help people in the community with their health?
Yeah, we have sort of a couple different tracks, I guess, of community health. On the one front, it's more about health promotion and access. So we have a mobile unit called the Wagner Wellness van. People might remember the large bus. Now we have more nimble, smaller vans that our nurses can just get in and drive and take anywhere.
Okay.
And they go out and they're doing diabetes risk assessments and educating people and doing blood pressure screenings, cholesterol testing, A1Cs out in the community in areas that we know are high risk because people lack transportation in that community, or there might be a lack of trust in the healthcare system. So thinking about like neighborhoods with more Haitian communities will go there and do screening and try to bridge that gap. And then the other side of it is, especially in Wicomico County, working with the fire department and the community paramedics. So we've already identified the people who are frequently calling 911. They have unmanaged chronic conditions. They're not emerging risk people. They are at high risk, and not just because of their medical needs, but because of all their social and environmental needs as well. So, so the team, I have community health workers and nurses and nurse practitioners, social worker that all work together on those cases to try to get their situation under control and work with them on their environment and their behaviors so that they won't have to use 911 or the emergency department so often.
And what are, that leads me to my next question, when you say chronic illnesses or diseases. So here, let's talk about Wicomico County, Eastern Shore even. What are we seeing the top three? I think I happen to know diabetes is probably one of them because our rates of diabetes here are through the roof. But I don't want to answer the question before I even ask it. What are those conditions that are really at the top of your priority list here in Wicomico County?
Well, so we do a community health needs assessment with the health departments to identify what those priority issues are. We do that every 3 years. So we've just finished the data collection, and now we're working with a consulting firm on developing the report. And from there, we make a community health implementation plan to address priorities. So the priority areas that keep coming up, we've kind of put them in 3 buckets. One is access and equity. Okay. So really looking at disparities and differences in people's health outcomes and what's contributing to that. Chronic disease and wellness. So in that area, we see a lot of heart disease, diabetes, high blood pressure, those lifestyle conditions, but also cancer and people not getting cancer screenings as early and as often as they need to, those kinds of things. And then behavioral health. So substance use disorder, mental health, and the stigma behind people getting treated for those conditions. Those are sort of all the things that we focus on.
You've got a lot on your plate because that covers a lot.
Yeah.
And your job then is to kind of disperse people out into the community to actually talk to the people that are going through these things to see what they need and how you can help them, right?
Yeah, and knowing that those are our priority areas helps us sort of focus on allocating resources or applying for grants to get initiatives started and be strategic. So we don't just say, hey, oh, there's a grant, let's go get it. We say, we've identified as diabetes and racial disparities related to diabetes and hospital encounters as being a really big problem here. So let's find what other resources we can bring together to address that problem strategically. So that's how this Health Equity Resource Community Grant came about. We're in the first year of a 5-year grant program funded by the Maryland Community Health Resources Commission with a coalition of partners, and it is specifically focused on addressing high blood pressure and diabetes in our communities and really specific interventions targeted at our African American and Haitian communities where there's higher rates of hospital encounters for diabetes and hypertension.
And you're like, okay, so why is this happening? how can we help support these communities so this doesn't happen, or prevention, or all of the things.
Yeah,
pretty much.
exactly. So trying to make evidence-based disease education, chronic disease education, diabetes self-management education available for free in the community, in community settings. Physical activity and food, making those accessible to people and understanding how those relate to those chronic conditions to prevent and to manage them. So we work with the health departments, but we work with Chesapeake Healthcare. We're working with Atlantic General Hospital, and we're working with community nonprofits like the Haitian Development Center and Rebirth and the library and others to try to tackle this from a lot of different fronts.
You're also dealing with, and forgive me, but you're dealing with people. So are the people in the community engaged? They want the help. They don't want the help. I mean, what are you hearing from the community at large that you're trying to assist?
Well, with our most recent needs assessment, we had focus groups. And we had a focus group specifically for Spanish-speaking individuals from the Hispanic community, and we had one specifically in Haitian Creole with our Haitian community members. And really in those groups, they want to be part of the solution. They don't want health officials coming in and saying, we've got this evidence-based program here, let's do a class.
Sure.
There is no evidence for Haitian immigrants coming here for what disease education model or program works for them. So we need to create it, and that's why they're part of the coalition to help co-design, what interventions they want and what tools and resources. And the things that keep coming up are food and transportation. I mean, if you can't get these basic necessities met, how are you supposed to even do any behavioral or lifestyle changes?
Right.
And you can't access healthy food or get to any doctor's appointments.
That's the bottom line right
Yes.
there.
Yeah. So we're really, really focused on those and health literacy. Because if you can't understand your own health, which even educated people, have trouble doing, then we need to address those. So those are really like the three ways we're trying to tackle the issue, I think. Health literacy, food, and transportation.
There are 3 pillars. In addition to that, though, I know I didn't mean to cut you off about the programs. You talked about the grant.
Oh, yeah.
Let's talk about some of the other wonderful things that you're doing out in the community.
Yeah, so going back, so we do the screenings. We have that grant program. Since, I want to say 2017, Tidal Health has had a partnership with the Salisbury Fire Department to run a program called SWIFT. And it stands for Salisbury-Wicomico Integrated First Care Team.
Okay.
And it was spearheaded by David Phippen. I don't know if you know him, but he's from the Salisbury Fire Department, amazing community paramedic, but so much more than that, and a true innovator. And he brought everybody to the table and said, what if we had this mobile integrated health community paramedicine program where a nurse practitioner and a paramedic were partnered, and they went into the homes and they assessed the safety of the home, the social issues of that individual, of these people who were calling 911. And so that program has continued to evolve. SWIFT has continued to evolve. And now we have another paramedic and nurse practitioner responding in real time to low acuity 911 calls at the same time as the ambulance. All over Salisbury. And if the individual consents and it's appropriate, they'll treat that individual. The ambulance goes back into service, and they've avoided an ED visit. So that's come about. Started with going into the homes after the fact, but now we've got both models going.
Because maybe people need to understand that 911 calls happen more than we even realize, right? People are just picking up the phone and calling 911.
Yeah.
When maybe, and I don't want to claim, oh, that's an emergency, that's not, but That's the go-to, and that can be avoided, or
Right.
Okay.
And with this program, we're catching those. So dispatch, they're sending them out. They understand what acuity level. Is this, an emergency, or is this something that maybe if we had an appropriate, provider could take care of it? So they even have, they can do some suturing. They can have medication starter packs, so they can start antibiotics or certain medications, and they can write a prescription for follow-up. So having that nurse practitioner with the paramedic has been so wonderful for the community.
Sure.
And throughout Wacomico County, with the home visits that they're doing, when people call 911, they know that that person responding is there to help.
Yes.
And, the fire department, on their shirt, they know that they're a helper and they trust them. And if they're a frequent caller of 911, they know each other.
Yes.
They've seen each other.
Yes.
So they don't know our nurse practitioners or nurses or community health workers from Tidal Health. So why would they open their door to us?
Right.
So that's where, us partnering with the fire department that was already a trusted resource in the community really opened the door for us to start to build a different kind of trusting relationship with those individuals.
And I think about it from just a person in the community. I want to avoid a trip to the ED at all costs. I don't want to go to the emergency department.
No, especially right now.
Yeah.
There's a lot of flu going around. Please don't go to the ED.
It's not. I don't want to spend 5 hours there. But
I started off the year there. I was there at 4 a.m. on January 1st.
Really?
Yes. I broke my elbow on New Year's. So I got to say, it wasn't busy at that time. So if you're looking for time to go to the ED.
Because everyone was sleeping.
Yes, I was in pain and said, honey, we got to go. I didn't just jam my elbow. Something else is going on
No, and
here.
that's an emergency.
Yeah.
Understandably so. But to prevent the frequent flyers, we'll call them, because that's their health care. They're like, oh, we're going to the emergency room.
Yeah.
But it doesn't have to be that way.
And when we were talking earlier about these issues, some of the people who are coming in frequently, there's unmanaged, undiagnosed behavioral health conditions. And again, I was mentioning the stigma and just limited opportunities for people to get connected to treatment, to have a peer working with them who maybe has overcome issues related to mental health or substance use. Those resources are really hard for people to find if they're not, used to navigating the system. And then we have a housing problem here, you tack on being unhoused on top of it, then it's almost beyond your control that you're going to have to use the healthcare system. But we need to pull together all these resources and make it a system, make it an ecosystem so that people aren't falling through the cracks and that there are resources.
They're being supported.
Let's wrap our arms around our community, our friends, families, and neighbors, as we say at Tidal Health, and wrap our arms around them and have a true continuum of care.
That is a great partnership with the fire department, because I didn't really think about, the trust that people build. Hey, I know your face, you're familiar to me, I know, I trust you. Healthcare system, maybe people don't trust so much.
Yeah, and when you go to the hospital, you get home and you're getting all these phone calls from the hospital. Why would you answer the phone, But, the paramedic can just knock on the door, drop by, they know who they are. So it's been an incredible partnership, and I'm just really proud to be part of that team and see the work that they do.
Sure.
Another program we do is Smith Island. So this is an isolated community.
It is.
If people get sick on the island, they've got to be helicoptered over. So prevention and management of chronic diseases is very important to us and to the residents of the island. So we tried to do a telehealth program, and we do some telemedicine, but again, it's trust. I mean, these are local people. They've been there for generations. So we actually have a medical assistant on my team who is a resident of Smith Island.
Okay.
we jokingly call her Dr. Quinn Medicine Woman because she wears a lot of different hats. She's
Yeah.
everything to everybody on the island. It seems like that's Janet Tyler. And our nurse practitioners, Erin Seabach and Tammy Walbert, when the boats are running regularly, the mail boat,
Sure.
they go to the island every other week from spring through November to see people for urgent and acute needs.
Okay.
We're always trying. My department is not primary care. We're trying to get people to have primary care, but we're realistic.
Sure.
So we know that there are needs, and if somebody's not going and sort of helping bridge that gap, then it could end up in a crisis, and we want to avoid that. So so that's another program that we do.
And once they're over there, they meet because they don't have a doctor on the island.
Right.
Wow.
Yeah, but since Janet lives there, she does blood work and she can set up the telehealth, for patients. But them going there, we usually send a pharmacist too, as well, and sometimes maybe a diabetes educator. We partner with the health department or our area agency on aging to bring other programs and services there. But together it's a great program.
It's not a house call; it's an island call.
Yeah,
it's bringing it to you.
Yeah, we use a little building that's owned by the church, and we used a grant last year from the Somerset Health Department to sort of retrofit it, kind of, so that we could have 2 exam rooms and have more true clinic resources there.
Right,
and so that's been a very beneficial part of our community health initiatives too.
You're reaching out to all communities.
Yeah.
I mean, your Tidal Health, but it's Somerset County as part of the Eastern Shore.
Yeah.
There's people everywhere.
Yeah, there's people everywhere. And it's really hard in a rural area. So when I got my master's in public health, and being from Mississippi, I was just really interested in the unique issues we face in rural communities.
Sure.
Without a transportation infrastructure, right? Without much public transit, with people, you can't just, not to say it's easier in inner city Baltimore, but you can go to a block and there's people right there that you can reach and give things to and do things with. But here, it's dotted little communities, so there's not like central places. So that's where we really tap into churches and any community centers and gathering places where we know people are. But we got to get more creative with how we reach people in rural areas.
Do you think that there is, because we're on the topic of rural and Maryland's Eastern Shore is a rural area, do you think that the healthcare concerns are I say different, but as far as chronic illnesses, we're different than other areas?
Yeah, if I had a map, I could show you. There's a lot of different indices and maps and things that kind of measure health and deprivation and vulnerabilities.
Yeah.
And we look at one called the Area Deprivation Index. I think it's from the University of Wisconsin. And it maps areas of deprivation, disadvantaged and socioeconomic challenges and health challenges. Red is the bad color. If you look at that map and you look at the Eastern Shore and as rural as we are, and you look at inner city Baltimore, it looks the same.
Okay.
Except, like I said, you blew it up and we're widespread, geographically widespread.
Right.
So we have those same chronic conditions, lifestyle, preventable chronic conditions that we're dealing with, but they're exacerbated by the poverty, the lack of education. Poverty plays a huge factor, and there's, we have a lot of impoverished communities here. So yes, I think it's more challenging than in a city.
Because it's saturated in a city, but this is widespread. You think you spoke about poverty because I think about the school system and how many children are living in poverty and on free and reduced lunches and stuff. It's a lot. So even I would say, community, like the school systems are a part of probably your partnership, because
Yes.
you need to reach the kids
Yes.
who are going to reach the moms and dads and the grandparents that, you have access to them through the schools.
Yes,
too.
and we do need to do more with our youth. There's a lot of opportunity there, and really expanding our partnerships with public health and the local health departments, who, are arguably the experts on prevention and youth programming. So, but Chesapeake Healthcare has also gone into the schools. There's school-based wellness centers. Tidal Health has school-based wellness centers in Delaware, in Seaford, Laurel, and Delmar.
Okay.
So when we identify youth that doesn't have health insurance, they're being seen in the school-based wellness center, that's a big red flag. If a child doesn't have health insurance, then there's probably a lot of other needs, especially related to health.
Sure.
And so that is an automatic referral for one of our community health workers, which is a really growing field of sort of allied health workers, to reach out and meet the parents and assess. They do a comprehensive, what we call social determinant of health assessment. And so they find out about primary care and insurance, but food, transportation, housing, financial assistance needed for utilities, the whole 9 yards, and work on prioritizing the needs with the parents,
Right.
so that we can help the whole family.
Well, I was going to say, if the child doesn't have it, then mom and dad probably don't have
Right,
it either,
yeah,
and
yeah.
it's a bigger problem.
Yeah.
So that's how you can identify then who you need to go talk to.
Yeah,
Okay.
and as a mom too, I know, my habits affect my kids. But if my kids, learn about something, I remember when my youngest was really small. He must have been 5 maybe,
Okay.
and he was in Cub Scouts, and they were doing something, and they fixed, like celery snacks with like some peanut butter,
Peanut butter
some
and
raisins.
raisins.
Yes,
Yeah.
the ants on a log or whatever. And he loved it. And he had never had celery before, and it like opened his mind. He's like, "Mom, I want that as a snack." And I was like, so sometimes, kids get excited about things in different ways. You can present it to them, and then they can bring those habits back into the family.
Absolutely.
And that one, I am pleased. I've done well with him. He eats salads. Now the other one, the older one, he just wants to eat chicken tenders and French fries. Not gonna lie. I mean, I try,
I know this. I think it's like something they go through, and then all of a sudden their palate changes. Like, oh,
yeah.
I like steak.
Now I can't take
Yeah.
the younger one out to eat because. He'll be he'll order everything on
Everything
the menu.
off
No,
the
he'll
menu.
want a salad to start,
They
and
don't
who
want
knows,
the kids' menu.
lobster or something. I don't know, but we don't take him out to eat anymore.
I think that's really important. It's not just education. It's really wrapping your arms around the whole situation.
Yeah.
And each family and what they're going through.
And there's a support network. And we've talked about youth and adults, but one thing that we haven't talked about that is related to this being in a rural area too, I mean, we have a lot of people coming here. We have a huge aging population throughout the Eastern Shore, from Sussex on down. And as people age, they're gonna get some of these chronic conditions more often than not. But a lot of people, and we see it with the SWIFT team, and people are isolated and they are lonely. And again, that contributes to mental health.
Sure does.
So we do a lot of partnerships with MAC Incorporated and the Area Agency on Aging. But as a healthcare system, I'm trying to, what can community health do? What can we do to be a more age-friendly healthcare system? We've got to prepare for this as a society.
We do. And we say prepare, there's so many different levels of that, because you're right, what does our aging population need resources wise, but even for their mental health and well-being. They might be isolated because the family might live 2 states away, or they just don't have people to come visit them, and then their mental health deteriorates. Like, it's a vicious cycle in a sense.
Yeah, yeah. I worked at Coastal Hospice before coming to Tidal Health.
Okay.
And I was part of their Compass program, which I don't think they have anymore, but it was for people who weren't eligible for hospice. And that's when I, went into the homes, and I saw a lot of people who were older, and, a lot of the kids had moved away. They'd moved across the bridge, and there's a lot of pride and individualism, and you want to be able to take care of yourself. And now I see, with my own parents, like they need help. They have each other,
right,
but they need help, and we're just not set up for aging as a community.
Right.
So I think there's a lot of work we can do in that area of
as well.
Community health. Yeah.
There's still work to be done, Kat.
Job security. I do love this work. If you can't tell, I get very passionate about it, and I'm very, very fortunate to work in a place that so many brilliant people we all really truly have the same values and mission at Tidal Health and our partners, and we want to put our heads together and work in the community to make it a better place and to improve the lives of the people we're working with.
Do you take information from people? Like, if people were to say, hey, I need to talk to her, or I need to talk to someone that works on her team, do you solicit?
Yeah, they could call us. Yeah.
Really?
Yeah,
okay.
Sure. My department's called Community Wellness.
Okay.
And, I'm happy to, Tidal Health, even outside of our department, sends people to do education presentations and does speaker requests. They can make that request on our website. We can bring our mobile team out to do screenings. We do a lot of that in local churches. They make a request and we come out.
Okay.
But if there's ideas that people have that they're interested in exploring, yes, we're open. We want to, like I said earlier, we need to co-design things. We just don't need to pick a neighborhood and say, we're going to bring this to your neighborhood.
Sure.
We would love it if people would reach out more, and then we can invite them to participate in the local health improvement coalition and really explore the different ideas.
And be a part of the solution.
Yeah.
I think. Kat, thank you so much for joining me today and helping people in Wycomico County understand exactly what it is that community health is and what it does and how they can reach out to you.
Thank you.
Thank you for joining us. I'm Jenny Pastasak with The Local Lens. We'll see you next time.